So here we're going to learn about vision in neuroanatomy. We're going to take some time to talk about eye anatomy itself, and then optic refraction and light detection at the retina, the focusing of light, and then also aqueous humor flow and glaucoma. We'll skip through phototransduction and retina histology, but we'll spend some time with the visual pathways and various visual field deficits. So first, eye anatomy. 3 layers here which we're going to learn. So first, this corneoscleral coat comprises the cornea, which is this transparent covering of the iris and the pupil. Then the sclera, which is this opaque, the white of the eye here. Next, we have the uvea, which comprises the choroid, the ciliary body, and then the iris. And then we have the neural layer, which is the retina here. Now, let's take this posterior region first. We have the retina, and then importantly, we have this optic nerve head here. So and then we have a photograph here of a fundoscopy of a normal eye here to show the relationship. So this optic disc or optic nerve head is here, and then this macula here. So this darkened area here is the macula with the fovea in the center, and then the optic disc has an optic cup, which is pale, surrounded by a neuroretinal rim, which is pink here. So next, we're going to talk about the anterior portion of the eye, the external portion that we can see with the naked eye here. There's a pupil here, which is the black portion here. Then surrounding it is the iris, which is this colored region here. Remember, the cornea goes over this, and we can see this corneal limbus, which is the edge of the cornea here. And then there's the sclera, the white of the eye, and then medially here we have the lacrimal caruncle and then the medial canthus. And then finally there's this palpebral fissure. And the palpebral fissure is the vertical height between the upper eyelid and the lower eyelid. And in certain disorders, there can be narrowing of the palpebral fissure. So let's talk about the focusing of light and aqueous humor. So basically, we're trying to take a target and we're trying to put it on the right spot of the retina. We want to put it on the macula, center of vision itself. So how do we do this? Well, we produce lens accommodation. So accommodation is a change in the refractory power of the lens to help focus light on the retina. And there's 3 different structures that are key to this. The first, the ciliary body here, it will contract for near objects and relax for far objects. The zonules will do the opposite. They'll relax for near objects and stretch out for far objects. And then the lens will become more round for near objects and flatten out for far objects. And we can see this aqueous humor production here coming out of the ciliary body and then going into the anterior chamber and then being reabsorbed in the canal of Schlemm. Presbyopia is a refractive error caused by a loss of lens elasticity, a loss of lens hardening. When it comes to aqueous humor, if there's an abnormality there can be an increase in ocular pressure, which is the basis of glaucoma. Now there's narrow angle, meaning that the fluid is unable to get out into the anterior chamber here. There's abutment of the lens in the iris here. And then there's open angle, which is an overproduction here, or an inability of the fluid to be reabsorbed at the canal of Schlemm here. And glaucoma therapies either work to reduce production of aqueous humor or promote reabsorption. In both instances, the point is to get the intraocular pressure down. So let's look at the surface of the eye here and its role in focusing light. So sympathetic will dilate the pupil here, whereas parasympathetic will constrict the pupil. And that's really core for the neuro exam to understand sympathetic pupillary dilation, parasympathetic pupillary constriction. Horner syndrome is an injury to the sympathetic pathway. So what's going to happen? Well, there's going to be constriction of the pupil. There's going to be ptosis. And the reason for the ptosis is eyelid droop from this superior tarsal muscle denervation. And then there's also anhidrosis, a loss of sweating. So let's talk about optic refraction and light reception here. So primary mediator of optic refraction is the cornea, its curvature. Secondary mediators are what we previously learned with the aqueous humor, lens, and then the vitreous humor as well. When it comes to light reception, these are the key differences between cones and rods, and you can learn this on your own there. And then this is the process of taking light through the lens and then placing it on the center of the retina here and the macula here. And then this is phototransduction. We're not going to go through this in detail, but you can see the basic setup. Most anteriorly are the ganglion cells here, then the retinal interneuronal cell bodies, and then the photoreceptors themselves right here, and then this is the site of phototransduction. And you can see how light goes in here, is received at the photoreceptors, and then passed back anteriorly here. The information's passed back anteriorly here. This is some refraction terminology, again, that you can learn on your own. Again, we're going to skip through phototransduction here. This is key neurobiology, and we're also going to skip through retina histology here, but we go through in more detail these different retinal cells. The visual pathways, this is really fundamental for the neurological exam here. Really important to have cold. Left visual field is received by the right occipital cortex, and then the reverse. And then when it comes to sagittal with superior inferior, superior visual field is received by the inferior visual cortex, and then the reverse. So let's go through the sagittal view first with superior and inferior. So the superior visual field here is received by the inferior aspect of the retina here. It's passed to the lateral geniculate nucleus, and then it's sent across along the temporal horn here via this inferior radiation to the inferior portion of the calcarine sulcus. And in opposition, the inferior visual field is received by the superior portion of the retina, goes via the lateral geniculate, goes to the lateral geniculate nucleus here, and then a superior radiation goes around the occipital horn to the superior aspect of the calcarine sulcus there. So now let's look at things in axial view here. Again, we have our eyes, we have our visual cortex, we have our lateral geniculate nuclei, the thalamus, and we've also introduced the optic chiasm because we're going to differentiate between nasal and temporal aspects of vision here. So central vision is going to go to the fovea, the central portion of the macula here. Let's first look at the left visual field. So there's going to be a nasal and a temporal aspect of things. So the outer portion of the left visual field is going to go to the ipsilateral eye, but it's going to go to the nasal part of the retina there. The inner portion of the visual field is going to go to the opposite eye, the right eye here, in its temporal region of the retina here. So let's look at this from the right visual field. Again, it's just the opposite here. So the outer aspect of the right visual field to the nasal aspect of the ipsilateral eye, then the inner aspect of the right visual field goes to the temporal aspect of the contralateral eye. If we take this visual field information though and we channel it through, we see that this nasal portion of the retina sends its information through the optic chiasm to the other side, whereas this temporal portion of the contralateral eye here goes straight back ipsilaterally through the optic tract, and they both meet up in the lateral geniculate nucleus. But look, they're meeting up in the lateral geniculate nucleus that's contralateral to the visual field because they're going to end up in the visual cortex that's contralateral to the visual field. And we can see that here. We talk about these optic radiations, and these are the superior and inferior radiations that we don't count for in axial view. We're going to learn this cold when we talk about visual field deficits here in a moment. So when it comes to visual field deficits, again, we have our axial view with our eyes, our optic chiasm, our geniculate nuclei, and our cortex here. We're just taking the left visual field here. Again, we see the outer aspect goes to the nasal portion of the ipsilateral eye, and then the inner aspect goes to the temporal portion of the contralateral eye, and then these projections meet up in this lateral geniculate nucleus on the opposite side from the visual field. And we can see that on the right side as well. And again, here's the inferior radiation and the superior optic radiation. But again, this visual cortex is contralateral here. So first, what happens if we have an optic nerve lesion? If we just have a lesion of the optic nerve right here? Well, the left eye is not going to see anything, whereas the right eye is going to be able to see all of the visual fields appropriately. So there's going to be monocular single eye vision loss. What happens if the optic tract, what's also known as a post-chiasmatic lesion happens? Well, this visual field is completely removed here. So in this instance, the right visual field is no longer being passed to the visual cortex. So there's going to be a hemianopia, wherein in this case it's the right side hemianopia, so the person is only able to see the left side of the world. We can break this down further if we look at the different optic radiations. So if a left superior optic radiation is affected here, then what's going to be missing is the right inferior quadrant here, and this is called a quadrantanopia. In contrast, if the inferior optic radiation is affected, then the superior quadrant is going to be affected. When it comes to an optic chiasm lesion, it starts getting a little bit trickier, but basically what you can think of is the nasal fibers are the ones that are affected. So only the temporal fibers, only the temporal projections are going to be preserved. So the only thing that's going to be preserved is inner vision, because remember, the temporal portion of the retina encodes the inner portion of vision. So visual cortex lesion here, now we would think it would be a pure hemianopia, but there's something called macular sparing, and there's arguments as to why macular sparing exists, be it for vascular reasons or for dual innervation reasons. Regardless, this is a pure hemianopia here. If the left visual cortex is knocked out, then the right visual world is not going to be observed. Left lateral optic nerve lesion. These last couple we're just going to skip through because they get a little more detailed than we need to. So there's a partial retinal lesion, and then there's also this thing called a junctional scotoma, which involves Willebrand's knee, and you can learn about that in more detail on the site. So that's a trip through vision, obviously a core neurological function.